Hello, good day, good morning, or good afternoon. So we'll wait for another few minutes before we get started. Welcome to the Journal Club. So I see Patrick Doeblin is already there. So is there, who will present the paper? Can you tell me?
I will present the paper for
Okay,
all.
great. Okay, so that I know. So good news for you because there is more. You will have more time because Dr. Kim unfortunately is not able to make it. These are the people from South Korea. I mean, it was sort of a little bit expected because the time zone is not very friendly for their participation. So I will just briefly walk through the other paper before we then hand it over to you so that you then present your paper. Okay, so we'll wait another few minutes or another minute or so to let others come in. Okay, so I will let you share your screen thereafter, but I will get started here. Okay, so welcome to today's CMR Journal Club. It will be me moderating today, and we have unfortunately Bettina will not able to make it, so we will announce the next journal club then online, or the contents of the next journal club. So for today we'll focus on two papers. The first one will be by Drs. Lee et al. From South Korea on image quality and diagnostic accuracy of T1 mapping-based synthetic late gadolinium enhancement, and a comparison with conventional late gadolinium enhancement in a real-life clinical situation. And then the other one will be presented by Patrick Doeblin from Berlin, called synthetic extracellular volume in cardiac magnetic resonance without blood sampling are reliable to replace conventional extracellular volume. So both papers sort of use sophisticated MR image data post-processing to facilitate cardiac MR scanning. And I think that's a very important goal for us. And there have been a couple of attempts recently to use such methods to, for example, get rid of contrast agents. And we discussed a while ago already a paper coming from Oxford looking at a method to use native T1 mapping based on the Schmoly sequence to generate synthetic late gadolinium enhancement images. And this is a very promising tool that they have. It's proprietary, so it's the Schmoly sequence, and it's currently so far mostly validated on Siemens, but it will come to other platforms as well. So this is a paper here from the Yonsei University College of Medicine in South Korea, in Seoul to be precise. They did something similar. They had 98 patients and they used 3 Tesla Prisma, so one of the more high-end machines, 3 Tesla Siemens machine, where they compared regular late gadolinium enhancement images with let's say a solid dose of 0.2 millimoles per kilogram of DOTA RAM in a standard application. And they used conventional late gadolinium enhancement imaging. And then they used a MOLY sequence with a 533 protocol, also fairly standard. And then they had a blinded analysis of image quality overall and the detection rate. And then also used a semi-quantitative analysis to look at the area and the fraction. So things we need clinically. Use standard statistical tests. And what they found is that the image quality, so the patient's characteristics are not that meaningful or that important. It's kind of standard. So they had a mix of cardiomyopathies, mostly non-ischemic cardiomyopathies, which also kind of reflects what we see clinically. And they looked at the image quality score, and here this is figure 1 that shows that. So the conventional is the light blue and the synthetic is the dark blue. And then you see the different observers, and you see the image quality score. 1, 2, 3. So with 1 being the best, then you can see that there were more in the better category when using the synthetic. So their major conclusion is that not only that the image quality is comparable, but they say actually it's actually better. So they did kappa analysis, and they all turned out to be pretty good. And then also when they looked at the area between the regular and the synthetic, there was actually no difference. So here are some, they did bland Altman analysis. So also the reproducibility all look pretty good. Here is because sometimes images say more than words, as you all know. So when we compare conventional and synthetic, at least visually, I mean, these images, of course, always the best are part of the paper, and at least in most papers. So we have to take it with a grain of salt. But if I compare visually, I see that some of them here, for example, case 2, clearly there was not the correct inversion time chosen, which may not be a problem when you look at the synthetic, when you compare it with synthetic, because this may be less prone to such errors. Of course, if you use the wrong inversion time, as shown here, if you use a PSIR, that is forgiving in terms of that error. But all in all, you see, at least visually, although they seem to be a little bit smoother, what you often see in these kind of synthetic images. And we all have to be, of course, aware that if you use synthetic images, there's always a certain risk that things are reconstructed that are actually not necessarily 100% reality. But all in all, I have to say that the data shown here really indicate that there's a significant potential of a synthetic method to generate late gadolinium enhancement like images of irreversible myocardial injury through the use of native mapping. So this is this paper. It's if you read it, I didn't find any let's say any red flags here. So this is to me certainly a very interesting an interesting paper that hopefully is reproduced sometime soon, and also on other machines, so that this method could help in many countries to get rid of the need for costly contrast enhanced images. Okay, so feel free if you have any questions or discussion points to just use the chat to jot them down. And now I would like to hand over to Patrick Doeblin from Berlin, who will talk about their paper published recently in Circulation Cardiovascular Imaging. And this time it's not about synthetic late GAD, but synthetic, if you will, extracellular volume. And of course, we know that one limitation of ECV imaging is the need for taking a blood sample, because the hematocrit is one value in the equation that is used to calculate ECV. So in order to get rid of that, there may be an alternative. And Patrick, I'm eager to hear from you what you found out in your study.
Thank you very much, Matthias. So let me first share my screen. Just a second. So you should see my screen now, I hope. First of all, I'm the second author. Most of the work was done by Wensu Chen, who unfortunately can't be here tonight, today. It's the evening in Germany. So what we did was we examined the relationship between the native T1 relaxation time of the blood pool and the hematocrit, because we know that the iron content in the blood pool has an effect on the T1 relaxation time, and we examined whether we can estimate the hematocrit from this T1 relaxation time of the blood pool. And even though we know this will not be a perfect correlation, we examined whether this is enough of a correlation to get an accurate estimate of the extracellular volume. The background is that it's always, of course, a little bit extra work to get the hematocrit of a patient, and it's not possible everywhere. Not every radiology practice has the possibility to draw to analyze blood, and we know from previous studies that the hematocrit actually can vary on a day-to-day basis quite a lot. If you take, for example, if you go through the ward and you check the patient's hematocrit on several days, you will get quite varying results due to the effect of diuretics, for example, or infusions. So especially for stationary patients, also it's quite important to have a very timely hematocrit, and this is not always possible. So our approach was to calculate the relationship between hematocrit and T1 relaxation time, specifically the R1 relaxation rate, which is the inverse of the relaxation time, because as you know from gadolinium contrast, there is a linear relationship between contrast agent concentration of a paramagnetic contrast agent and the relaxation rate, which is the R1, which is the inverse of the relaxation time. And so because blood and the iron also has some ferromagnetic and paramagnetic effect, we also examined the R1 relaxation rate. What we then performed is not a standard regression, but a Deming regression. The difference is small but important in this case. That a Deming regression is also called an orthogonal regression because it accounts for measurement error in both variables. This is important because there will be measurement error in both the independent and the dependent variable. And if you do a standard regression, you will underestimate high values and overestimate small values of hematocrit. And this is actually what happened in a lot of previous papers that you see on synthetic hematocrit. You will always find that they will underestimate high values of hematocrit and overestimate low values of hematocrit. And this can be overcome by applying a Deming regression, which we did here. And from this, we derived the formula in a derivation cohort of 550 patients on both 1.5 and 3 Tesla scanners. And we applied this to a validation cohort of the same size, and we validated this to check for accuracy of the calculated synthetic hematocrit against the measured hematocrit and the synthetic ECV against the measured ECV with the blend alpha analysis. So let's go to our results. So we did a lot of subgroup analyses, but I think the important results are here. The measured hematocrit, this is from the derivation cohort. So this is where we derived our calculations, our equations. This is the correlation between LV blood relaxation rate and measured hematocrit. And we also performed the same calculation for the RV blood relaxation rate. and there was a linear correlation. As you can see, of course, the correlation was not perfect. There were some outliers, but when applied to the validation cohort, we found actually quite a satisfactory correlation on looking at the ECV here. For example, if you look at the measured, sorry, jumped back. So I'm not sure if you can read the numbers here. So we have here the measured ECV against the synthetic ECV. And the correlation coefficient was 0.87, and which gave us quite a good approximation of the measured ECV. We validated this also in a cohort of patients with amyloidosis, because these are usually the patients where it's most interesting to get the ECV. So this on the right side, you see here, this diagram, you see the measured ECV and the synthetic ECV in amyloidosis patients. So the green is the measured, and the blank circles are the synthetic ECV in amyloidosis patients and in non-amyloidosis patients. And you see that very well there's the same cutoff of about 30%, above which we'll have the amyloidosis patients, and most of the non-amyloidosis patients will be below that. So this is, and also you see here the limits of agreement of our patients in cohorts without anemia and with anemia. And these are the results from our deeming regression here, the specific models. We show less deviation in the anemia cohort compared to regression with the standard regression and not using a deeming regression. So yeah, these are our main findings. It is a possibility to use synthetic hematocrit. You can reliably discern amyloidosis from non-amyloidosis patients without the need of drawing blood. So other questions regarding the study?
Yeah, thank you very much again. So whoever has questions, either just unmute yourself or otherwise just put it into the chat. So I have a few questions. First of all, did you compare, because the deeming versus the standard regression method, so can you expand on that a little bit? How big is the difference, and did you compare them in the sense of what is the impact of overestimating the low values, underestimating the upper? So how important is that? Because I mean, better methods are always better, but just to get an understanding, also in comparison with previous papers on a similar topic.
So the deeming regression does not allow for multiple regressions. So we had to calculate specific models. Sorry, I'm getting to your question. So what we did was we made a common model which was derived by multiple regression, including multiple inputs. And this is what you see here. But this was performed with standard regression, with multiple regression. And then we did the same with the deeming regression, but we had to specify several different models here, because the deeming regressions allows for only one input and one output variable. And what we did then was we compared the results from this multiple regression model with the results from our deeming regression models. And that's what I showed you here. And you see that compared to the cohort without anemia, in the cohort with anemia, the model that uses a standard regression, the multiple regression here, shows underestimation of in a mean of about 2.5% of the ECV, whereas the deeming regression fares a little better. The difference is not that much, of course. So, but it might be just what tips you over the line in patients with anemia.
Although, I mean, the overlap is pretty substantial, so
of course,
I'm not sure whether it's statistically significant. Yeah. Okay, but maybe that's a more of a detail. Another question I had is when you go to when we say it's clinically useful, one parameter to look at that, of course, is accuracy and reproducibility. But eventually, it is about the question: what is the impact on actual clinical decision making? So did you, and I may have missed that, but did you analyze in how many patients you would have come to a different clinical decision with this one versus the standard approach?
Yes, we actually did a misclassification analysis. Let me just look it up. So there was a misclassification using a slightly lower cutoff of 29.5% for synthetic ECV. About 6% of all patients in the validation cohort showed misclassification, with about 4% false negative and 2% false positive.
So overall, you would say, okay, there may be a very small number of misclassification, and they may be whatever. In medicine, we always deal with some noise, so even the standard method may be wrong at some point.
Yeah, you have to keep in mind that hematocrit is also very can be also very variable. If you measure the hematocrit twice in one patient in 2 different days, it can vary quite a lot. But of course, there will be some inaccuracies using this synthetic hematocrit, which have to be accounted for. But I think there might be situations where this is useful when you don't have access to rapid hematocrit testing.
So given, if I may just say, interpret that, so given the advantage of not having to have a blood sample, risking that some patients may not be scanned on that day, decisions may be delayed and such, and also, as you said, the given variability of spontaneous hematocrit values based on the fluid status and all that. If you take all these disadvantages of conventional blood sampling and compare it with a 6% misclassification, then overall it seems like a very useful approach. It saves time, it saves cost. So in one quick question I have is another is the validation and the derivation, because I was a little bit confused. You sometimes use the entire cohort. So how can you quickly run through that? So in how many did you develop, and in how many did you then validate in terms of percent of the total sample?
50%. So we split the total group of 1,101 patients in half. So 550 were part of the derivation and 551 were part of the validation.
So this is for everybody. This is, I think, important, because some studies have been published where basically 80% are derivation and then only 20% are used for validation, and that may skew it a little bit. So and the normal distribution, I guess you verified that both samples have equal, basically can be considered equal in terms of the overall expected phenotype. Okay, there's a question from Rigur. If we directly input hematocrit as 45%, how is the difference between actual CV and synthetic one?
That would be an interesting question. We can run the models again with just a fixed hematocrit at 45%. Would be very interesting.
Yeah, so maybe that's something you can do on a Friday afternoon when the rest of the work is done. Okay, so are there any other questions from the group? So just one last one then if not, then from me. Are there any follow-up projects planned, larger samples in other patients using other scanners, and And what is, if people want to do that now, what would they need in terms of hardware, software?
Well, we validated this on a Philips scanner on 1.5 and 3 Tesla with different models for males and females. I think regarding validation, at least for our clinic, we are quite confident now. Of course, it has to be seen whether this holds up also for other scanner types. Yeah, at the moment, I think we have quite a large sample, and it will be very hard to get a even larger sample now as a follow-up project here. So, but we will see how it holds up in terms of influence on outcomes. We're planning to do an outcome analysis, whether it predicts outcome compared to the measured ECV. So to see whether those two are really interchangeable for clinical decision making.
Okay. And do you think, so if people would actually want to try this now, so you have this table that you're or also, I think, currently sharing on the screen, but this is for Philips scanners. So do you think that we would need such a table for all the different scanners?
Well, the problem is that the T1 relaxation times vary between scanners.
Yes.
It is a common, a known problem we know from T1 mapping of the myocardium, and I expect nothing less for T1 mapping of the blood pool. I think the underlying relationship between blood T1 relaxation time and hematocrit will be the same in terms of direction. But of course, you have to account for differences in measured T1 relaxation time.
Okay.
So
yeah, so we at McGill we have actually data from what we call the 3 scanner study, where we compared 3 different scanners with the very same people and with T1s. So we could certainly run that and compare 1.5 versus 3 versus different vendors, and see how much this affects the actual measured hematocrit. Yeah.
it's an easy analysis. You usually have all the data you need from the images.
Yeah. Okay. So thank you very much. So if you could unshare your screen. So oh, sorry, there's one other question from Niels Menk. How many patients do I need to validate this model on my Siemens scanner? So what do you think Patrick, how many patients one would have to do to?
Yeah, I think to accurately assess this, let's see, just a second. I can't find our power calculation here. It's hard to say. I would probably start with maybe 100 patients and see whether you get about the same direction. And yeah, but
Yeah,
I'd have to do the power calculations for that. Maybe get involved with a statistician on that to see what the numbers would be you need to confirm that.
This may actually, if I may leave a little recommendation. So if someone would have the time from your team, I think this would be an interesting and important publication to say, based on our data, the power calculations indicate that in order to do that clinically, in this sample of patients with an expected sample, you would need that many people to validate this on your scanner. think this would be a very practical and useful paper, and I'm sure JCMR would be very happy to accept that fairly quickly. Because often these things they kind of die on the home stretch because people do not know how to actually practically apply them. So this would be a very helpful information to that. Yeah. Okay. So thank you very much. I will just briefly mention that probably next time, but I will have to verify with the authors because that's from Australia. But there has been a very interesting paper by an Australian team, and let me just share that on the screen, that we will discuss next time. And it is about, I cannot share right now, which will be about the use of cardiac MR in transplants. And there has been really a large number of papers indicating that T2 weighted imaging, or T2 mapping for that matter, may be a very useful tool in monitoring patients after transplant surgery. And a lot of these papers actually showed very similar things, but it was not picked up. But now this study in 400 patients was controlled with endomyocardial biopsy in about 100 of those, and these are very interesting results. So next time, which will be beginning of July, we will then discuss about the role of cardiac MR after transplant. So I hope you can join then, and until then, I wish you all the best, and be well, stay safe, and we'll see you then in a month. Thank you very much, and thank you very much, Patrick, for the presentation and the good discussion. Bye.
Bye, thank you.